Okay, I think we'll get started. Welcome everybody to Pediatric Grand Rounds. I'm going to turn this over to our Vice Chair for Education, Sandrain Van Schaik, to get us started and introduce our speakers for today. Sandrain.
Thank you, Dr. Hurst. And welcome everybody to Pediatric Grand Rounds. We have a panel of speakers today who will talk about suicide risk in pediatric hospital settings and what we can do about it. Our speakers include Dr. Kjati Brambat, Dr. R.P. Beck-Mazian, and Dr. Nora Pfaff. Dr. Kjati Brambat is an associate clinical professor at the UCSF School of Medicine in the Department of Psychiatry. She came to us in 2014 from UC Davis after she completed psychiatry residency and a chief residency at Albert Einstein in Philadelphia, followed by a child and adolescent psychiatry fellowship at MGH in Boston. Dr. Brambat is the director for the Child and Adolescent Consultation Liaison Service at the UCSF Benioff Children's Hospital. In this role, she is responsible for conceptualizing and implementing collaborative mental health services within pediatric inpatient and specialty outpatient settings. She is also very interested in systems of care and how they can be adapted or modified to improve patients' mental health outcomes in consultation liaison settings. She chairs a work group within the Physically Ill Child Committee that will address this need through the creation of clinical pathways. Dr. R.P. Beck-Mazian joined UCSF in 2008 and is currently a clinical professor of pediatrics in the Division of Pediatric Hospital Medicine. She serves as the Executive Medical Director of Quality and Safety for the Benioff Children's Hospital. In this role, she provides leadership, direction, and oversight of quality and safety initiatives and is charged with the development, coordination, implementation, and administration of strategies to improve BCH quality and safety. She's an elected member of the UCSF Executive Medical Board and a member of the Society for Pediatric Research. She has a certificate in advanced improvement methodology from the Cincinnati Children's Hospital and is a graduate of the California Healthcare Foundation Healthcare Leadership Fellowship Program. Dr. Nora Pfaff is an assistant professor in the Department of Pediatrics within the Division of Hospital Medicine. She also serves as the assistant director of the UCSF Northern California Consortium. Her research passions involve ways to bring opportunistic care to patients in the hospital setting, and thus far have involved HPV vaccines for inpatient adolescents, high-risk behavior screening and interventions for hospitalized adolescents, and most recently, social determinants of health screening and interventions. She's also involved in advocacy through the local AAP chapter and serves as a state government affairs representative for AAP California. And with that, I'll hand it over to, I think, Dr. Brambat, you're going to get started.
Yes, thank you very much. And thank you for everybody who's going to be watching this remotely. And I appreciate the opportunity to come here today and present on this topic. And just a quick update that the name of our department recently has been updated to Department of Psychiatry and Behavioral Sciences. These are all our disclosures. As you can see, we have nothing to disclose. And as we go through the talk today, you'll start by hearing a little bit about, why we think there is a need to assess and screen and manage suicide risks, starting with talking about a case, and how pediatricians interact with that through HEADS assessments in pediatric settings, and then how we can take that and implement more systematic pathways and workflows to address this more broadly, and then some preliminary outcomes about our implementation efforts at the San Francisco Hospital. And with that, I'm gonna hand it over to our first speaker, Dr. Beck-Mazian.
Great. Thank you, Kjati, and hi, everyone. We're excited to be presenting to you all. We thought we would start with a patient story. This is based on true events, but we changed a lot of the details to protect the patient's privacy. So Gabby was a 15-year-old female, history of chronic migraine, who was admitted for dihydroergotamine infusion. For those who may not be familiar, dihydroergotamine is or also known as DHE, is an ergot alkaloid used to treat refractory frequent headaches. Oops. Her past medical history was notable for chronic migraine. She had failed multiple medications, both abortive and preventative, due to intolerance of side effects. She had also been diagnosed with depression and anxiety since her last admission to UCSF. Her home medications included sertraline and naproxen as needed, and she participated in weekly cognitive behavioral therapy. Her hospital course was pretty unremarkable. She was admitted for a routine 5-day DHE infusion. She didn't have any complications of her infusion. Child Life noted flat affect, but no other concerns were raised. She was counseled that the headaches would take about 4 weeks to respond to the DHE infusion. A migraine device, a trigeminal nerve stimulator, was ordered, and she was prescribed chlorpromazine as needed for acute breakthrough headache management. 2 weeks after discharge from the hospital, we heard that Gabby was found having taken the whole bottle of the chlorpromazine with suicidal intent. She was admitted to an outside hospital with prolonged QTC. Fortunately, she recovered from this event and was transferred to a psychiatry unit once stabilized. We were able to debrief with the outside hospital and learned that there had been no escalation of headaches prior to the event per patient, and she had reported that the headache pain was not the cause of her suicidal attempt. This case identified several opportunities for learning and improvement, including asking and talking about mood and risk behaviors, updating the problem list with new diagnoses that may have been made since last admission, updating the social history, using a head screening tool, which you'll hear more from Nora about, and opportunities to standardize overall risk assessment for all patients, which Kiari will speak to. And with that, I'll turn it over to Nora.
Thank you so much, Arpi. And okay. So as Arpi mentioned, I'm going to talk a little bit more about the HEADS assessment tool that we have at our disposal as pediatricians. So the AAP and Bright Futures recommend annual risk behavior screening and psychosocial screening for all adolescents. And this is usually done by their primary care provider using the HEADS framework, which was first described in the 70s as a way to do a psychosocial review of systems for adolescents from the typically least sensitive to most sensitive topic. Screening is so important because these risk factors do contribute to the leading causes of morbidity and mortality in adolescent patients. Unfortunately, as we know, adolescents have low rates of preventive care visits with a pediatrician, so increasingly, other venues such as the emergency department have been seen as a great opportunity to screen and intervene on these risk factors. And there have been limited studies on inpatient setting screening and interventions and what we can do there. Which leads me to our work at BCH Mission Bay, where we conducted a cross-sectional retrospective study looking at 12 to 24-year-old patients admitted to the Pediatric Hospital Medicine Service between January and December of 2018, and we looked at a random audit sample of 20 charts per month. We excluded patients who were found to be nonverbal, or rather documented to be nonverbal, who had altered mental status or were transferred to another service such as the PICU, TCUP, or adolescent medicine, as they have their own more rigorous screening protocols on the adolescent service. The primary outcomes that we looked at were physician documented risk behavior screening, and we looked at a secondary outcome of risk behavior related interventions that were done in the hospital. We looked at these two outcomes independently of each other to assess for any association. I'm going to present some results that are specifically relevant to this talk, and out of the 240 charts that we looked at, 73, or about 30%, had documented screening for mood disorders, and 23% had documented screening for suicidal ideation. Of those with documented screening, 62% had positive screens for mood, and 22% had positive screens for suicidal ideation. And remember, these were random samples and not specifically patients who had been presenting with behavioral health issues. The clinical interventions that we then looked at specifically related to suicidal ideation in our study included interventions such as social work referral and notes, inpatient psychiatry consults, outpatient behavioral health resources, and any inpatient suicidal ideation precaution orders. And these included things like removing sharps from a patient's room or placing a one-to-one sitter. And when looking at the rates of patients who received any of these interventions, 83% of patients who had documented positive SI received an intervention, 39% of patients with documented screening, whether positive or negative for SI, received an intervention, and 5% of patients who did not have any documented screening received an intervention. And remember, this is a retrospective study, so it's all based on documentation. Those 5% could very well have been positive and screened, but just not documented. So our overall results showed that there was low adherence to recommended risk behavior screening of inpatient adolescents. And those who were screened and documented had high rates of positive screens. And we found that patients who are screened, patients who are screened are significantly more likely to receive risk behavior related interventions. Some quality improvement efforts that are currently underway to address these low rates at our hospital include a HEADS Smart Phrase and APEX template for physician notes, and an eventual integration of an outpatient tablet screening tool that has been developed by Dr. Elizabeth Ozer and her colleagues in the Division of Adolescent Medicine. And these self-disclosure screening tools have been shown in literature to increase disclosure. Now, I mentioned earlier that risky behaviors contribute to leading causes of morbidity and mortality in adolescents, and truly suicidal ideation contributes the most. And so I'll hand it over to Dr. Brambot to tell us more about that.
Thank you. Okay. So what I'm going to do is really start by zooming out a little bit to look at the big picture of suicide across the globe in our country. And really, you'll also hear from RP about how that informs some of our policy and regulations, and then sort of zoom back into what have we done at our hospital, what are the outcomes of that, and maybe we can have hopefully a discussion from that about next steps and your thoughts about what you've heard. So, why I hope I don't have people who are not, or who are non-believers, but I hope to convert a lot of people into stronger believers in that suicide is really a global health emergency. And if you look at numbers across the globe, and these are numbers from the WHO Global Health Estimates, in terms of leading causes of death in youth from 15 to 29 years of age, when you combine both male and female sexes, suicide is the second most common or the second leading cause of death. There's a slight difference where if you segregate it by females, it remains the second leading cause, and then it drops down to the third leading cause in males, where interpersonal violence is a bit more prevalent. If you look at these numbers in our country, in the US, it is still the second leading cause of death in the 10 to 24-year-old age group. And it accounts for 20% of all deaths in that age group. So it's a big chunk of what leads to death in this age group. If you break it down further by age, with sort of 10 to 14-year-olds versus 5 to 10-year-olds, we see that the gender trends are different compared to the global scenario. So here we have more males represented. So it's the second leading cause in males and third leading cause in females. And in that age group, it has the total number of deaths from suicide has now surpassed that from car accidents and drowning put together. And then in the 5 to 10-year-old group, and this is really where there's a lot of alarming, because it was not even in the top 10 causes of death, but it has now moved into that in 2018. And we are seeing that that's a number that's rapidly increasing. And we still see the same sort of gender difference in male versus female, which is different from the rest of when you look at the WHO, where females are more than males. So when we think about all of this in a hospital setting where we're working with, kids with chronic illnesses, how does that compare? So when you look at 10 to 14-year-olds and top 10 leading causes of death, barring, when you sort of put homicide aside, which is always going to be very, up there in the numbers, the number of kids who die by suicide is more than malignant neoplasms and heart disease combined. When you look at the young 15 to 24, barring homicide, it surpasses all the other causes, all the other illnesses that we deal with. And so this to me really says, for all of us who care about kids and morbidity and mortality and their health and well-being, we really have to care about suicide because this is a big problem. And there are also many challenges as we think about, all right, so how are we going to address this? The biggest thing being, a very small number, so 30% nearly, are the only percentage of those kids who are experiencing suicidal thoughts will share it to an adult. So think back to the case example that you heard RP talk about, where that patient did not share the suicidal thoughts, or maybe, they didn't have it, but we don't know. But there is the other side of this where 80% of those who die by suicide have seen a healthcare provider in the last year and 40% in the last month before they complete suicide. So this is really sort of an opportunity where we can screen and intervene and have early recognition of suicidal thoughts and intentions and put in place some interventions. The challenge is always that a lot of these healthcare settings are not psychiatric settings. They're seen in pediatric settings, and pediatricians, for the most part, are not trained to do this in a sort of in-depth, detailed way. And that can present sort of a challenge and a roadblock to intervening early on. And that's where our sort of team, the Physically Ill Child Committee that you heard about, it's a committee of the American Academy of Child and Adolescent Psychiatry. And our goal is to really focus, we are all experts in the area of mental health in chronically ill kids. And we formed a clinical work group that basically wanted to take clinical care, things that are encountered in pediatric hospitals and the reasons that child psychiatrists get consulted, and then put together workflows, because sort of the current consultation model requires that somebody identifies a problem and then calls, and a lot of the times we don't even get involved. And so we really needed to sort of have something that goes upstream. And what we did is applied for a grant that was funded, the ACAP Abramson grant, and we used that to conduct a work group retreat. We invited pediatricians who are experts in clinical pathway processes, and we put together our content expertise and created clinical pathways for the top 3 things that are seen in pediatric hospitals, and that include suicide risk screening, somatic symptom-related disorders, and delirium, and we'll talk more about the suicide risk screening. We also did a lot of stakeholder feedback, and then all of this has been published in a manuscript that came out in 2019 to help take what we know and then implement it in pediatric settings. I think, pediatricians are much more familiar and much better at clinical pathways, implementing them, creating them. All the way back in 2003, 80% of US hospitals were using at least one clinical pathway. You might be more familiar with the ones that are used for things like asthma, diabetes, GI issues. They haven't, however, been used for mental health in pediatrics per se. So these pathways are sort of trying to take a process that everyone's familiar with and applying it to a new problem. So the pathway that we created is a 3-step pathway. It starts with an initial screen, which is a very brief 20-second screen. And then based on the results of the screen, you can have the need for a brief suicide safety assessment or a full mental health evaluation, or maybe both, depending on how things go. And I will talk to you a little bit more about the details of that. So what is the initial screen that we use? We use the ASQ, or the Ask Suicide Screening questions, not to be confused with the other ASQ that pediatricians are more familiar with. And it's a 4-question screening tool. There was a lot of research that went into the language that needs to be used in this tool, and it's been validated specifically in medically ill kids in pediatric hospital settings. And by now it's been validated in outpatient for adults, and even starting to get validated in school settings. So the questions are: in the past few weeks, have you wished you were dead? In the past few weeks, have you felt that you or your family would be better off if you were dead? And in the past week, have you been having thoughts about killing yourself? And have you ever tried to kill yourself? If yes, how and when? So if there's a yes to any of these questions, then you get asked a fifth question, which is called an acuity question, which is, are you having thoughts of killing yourself right now? So based on how the patient responds, if it's a no to all questions, and that's a negative screen, if, however, they do not respond to one of those questions, then it's considered automatically a non-acute positive screen, which means that they said no to question 5. And the reason for this is that they've done a lot of research and looked at the kids who don't respond or refuse to respond. When they've gone in and done a little bit more of an investigation of that, those actually were kids who were at higher risk based on a clinical evaluation. If, however, they say yes to any of the first 4 questions, you ask the 5th question. If they say yes, that's an acute positive screen. If they say no, that's a non-acute positive screen. So for those who say, no to question 5, but yes to one of the first 4, they get a second step of the pathway, which is a brief suicide safety assessment. And this is an assessment that starts by sort of acknowledging with the patient that these are hard things to talk about and that you're very glad that they did share this information. And then you assess more in depth sort of frequency of suicidal thoughts, if they've had a plan, symptoms for underlying mental health diagnoses that can contribute to suicidality. It goes through depression, anxiety, some impulsivity, recklessness, substance use questions. What's important here to understand is that it's important to go through this and screen specifically for suicide and underlying conditions, and not assume a strong connection between depression, because in kids there's a lot of data that things like bullying and other social stressors have a much larger contribution to suicidality compared to adults, where depression or mood disorders and suicidality have a much stronger link. And that's really important to remember for us. And which is why, things like the PHQ-9 or screening for depression, even though it has a question about suicide, is actually not going to get you true suicide risk assessment. You think about past behavior, you ask about sort of preventive factors and protective factors with social supports and stressors. And this is where bullying and other things are talked about. And then finally, you make sure that you get the perspective of the parent, the guardian, or caregiver, and make sure they understand, why we're asking and get their input. And then finally, make sure that we make a safety plan with the patient. So after this assessment, if somebody feels, well, there is really such high risk that we need to do even more in-depth evaluation, that's when you can do a full evaluation with a child psychiatry specialist. And that's where and if not, then you kind of figure out disposition, if connection to outpatient care is needed, and provide resources such as National Suicide Prevention Lifelines or crisis text lines. All of this information is in the manuscript. It also includes an introduction document, so that if you are thinking, okay, I need to do this, in my sort of clinic, and how do I just talk to all the clinic providers or leadership about why we need to do this. The document outlines all the sort of reasons why we need to do this, how we can do this, and then some details in the text pathway of why each step in this pathway was picked, what's the evidence, including then scripts to help implementation, so that, when people are still learning to use the language and learning how to do this work, there's scripts to introduce why we're screening, how to screen, actual things to say in response to the questions, and so on and so forth. So our hope with this is that it becomes really easy for people to implement this, and that when you can, take it to your clinic, that you have everything you need to do it. And if you need even more support, this is where like our regulations and things like that can come in and help us make that argument. I think clinically, there's already plenty of argument, but it's also important to understand what the policy and requirements are around that. And I'll have RP talk to us a little bit about that.
Great, thank you, Kiati. So it was really opportune time, because just as Kiati was working on publishing her team's work and thinking about implementation, the Joint Commission started regulating patient screening. You might ask, why did they get into this? Why did they do this? Well, the majority of suicides occur outside of healthcare facilities, but many suicides occur within healthcare facilities, and even more suicides occur shortly after hospital discharge, like our patient's suicidal attempt. Suicide is in the top 5 most frequently reported sentinel events to the Joint Commission. In 2007, Joint Commission had released a National Patient Safety Goal, 150101, requiring that we screen all behavioral health patients in all settings. This also applied to patients in psychiatric hospitals and patients who express suicidal ideation during the course of care. Then between 2010 to 2014, more than 1,000 patient deaths from suicide during or within 72 hours of discharge from a hospital were reported to Joint Commission. So in 2016, Joint Commission released Sentinel Event Alert number 56, requiring screening of all patients in all settings. They cited that patients being treated primarily for medical conditions can have comorbid behavioral health conditions, just like our patient, and psychosocial stressors, raising their risk for suicide. So it wasn't enough just to target the patients who were admitted for behavioral health concerns or who were in psychiatric hospitals. This requirement was also endorsed by CMS, Centers for Medicare and Medicaid Services, and subsequently BCH leadership decided to adopt universal screening for all inpatients and ED patients. And Kiari will talk a little bit more about that implementation.
Thank you. I just, before I move on, I saw a question about what does the now in question 5, mean, and it means right now as you're talking to them. And then to answer the other question about who does each of these steps in the implementation, the idea is that usually the initial screen across the country, and now I've helped it implement in Canada and a few other countries, it's usually sort of bedside nurses or triage nurses, depending on which location you're at. In outpatient settings, there have been, different workflows based on who's there, but it could be the front desk person or the nurse who's, doing the vital signs. So it really depends on who your clinic has and what resources are available or what your individual inpatient unit has available. And so in our hospital here at Mission Bay, the initial screen is done by the bedside RN on the inpatient side, and then the brief suicide safety assessment is done by our social work colleagues. And primary team, there's an increasing sort of discussion around involving hospitalists in the ED. I know some of our emergency room providers are doing some of the BSSA screening. And then finally, I think my slide is not moving as, okay. Finally, the full assessment is done by the child and adolescent psychiatry team. So I'm not talking about too many details about the implementation in terms of the process, but I do want to share some, things that helped us. So we made sure that all of these questions were in our EPIC system so that it was going to become easy for when the nurse is by the kid's bedside, they can pull this up and click on the responses that the kid gives. And then based on the responses, the next pop-up will be things that are automatically put in place. So for example, for a non-acute positive screen, self-harm precautions, or if needed, safety attendant at bedside, notifying the nursing supervisor, food tray, all of these things can automatically be put in place. And that's really helped us do a good job with screening. And if you look at just the broad numbers from a 12-month period, we screened 659 kids, and then that's roughly around an 80% screening rate, which is pretty good for sort of something that we were trying to do hospital-wide. Most of our kids, 85% were negative. Of those that screened positive, 1.3% were acute positive, so about 48 kids, and 263 were non-acute positive, so that's about a 7% non-acute positive rate. And ultimately, 25 of the 48 ended up needing hospitalization, and those that were acute positive, when they were non-acute positive and our social work colleagues did the BSSA, 54 of those kids were thought to be high risk, needing further child psychiatry consultation, and then ultimately 19 or 0.5% ended up needing hospitalization. So what's really interesting is, when you look at acute versus non-acute positive, about the same percentage ended up needing psychiatric hospitalization. And so that's something to keep in mind in terms of acuity versus non-acuity. And then also, thinking about, well, are most of these cases that we are identifying because they have, they're presenting with psychiatric complaints or a history of psychiatric conditions. And that actually, when you look at acute positive, that's true that with the acute positive patients, a majority of our patients had a prior psychiatric history or a chief complaint, but even so, 27% did not have any prior psychiatric history, and 10% did not present for a psychiatric complaint even when they had a history. In the non-acute positive group, that's a really big percentage. So about half did not have any prior psychiatric history, and the majority, 70%, did not come or present for a psychiatric complaint. And this, to me, really talks about why it is very important that we screen more broadly and not limited to patients who've had psychiatric and behavioral health challenges. Sort of that we keep doing this work. And as we've been doing this now, we've started also looking at it more closely unit by unit. And I don't have numbers for the entire 3659 sort of N that we had in the prior two box charts that you saw. But we did look at a smaller subset of 1,500 to look at implementation by unit so we can figure out where do we need to do a little bit more support. And so we are seeing the rates are very different. In the med-surg unit, we're seeing 90% screening rates. And in the pediatric cardiac ICUs, 39%. And a lot of this is also given the acuity and what they're dealing with. And our hope is that we can now sort of look at how we can improve upon these numbers and go, do a better job globally. So I think this was sort of what I hope helps you get a good sense of what our numbers look like and what we can do to help improve this problem. So I know we have a ton of time for discussion. These are all the references that I have used all along the slides. I just want to also acknowledge none of this would have been possible without, this is a really heavy lift. And none of this would have been possible without like an amazing team. And I, really want to thank our nurse practitioner, Brian Wasowski-D'Antoni, who's been like great in helping a lot of this implementation. All of our nursing colleagues, the leadership with Megan Yee, Bart Reyes, and Curtis Wong, and Denart, but also all our bedside nurses who are really doing our initial screen and implementing this. And social work colleagues who are doing the BSSA with Rebecca Gates as their leader, but everyone has, been really great in how they've helped implement this, and all our hospitalists and intensivists, subspecialty providers, and our ED team. I think, it's, we've had great support even there with Jackie Garfillon, who's leading it, Stephen Bin, Barbara Feldhauser, Hannah O'Donovan, and Nisa Adiga Pramod, who's been helping now more with the implementation and looking at how we're doing. And again, the broader sort of my national team that has been working on creating these pathways and implementing it at various sites across the country and in Canada. And the other thing I want to say is, as we've been looking at all of this, we have started to talk about, well, these numbers were so high to begin with. What's happening as a result of our current reality of living in COVID and what those numbers look like? If you look at the discussions and the preliminary data that we're getting, those numbers are going up even more at a really alarming rate. And there's actually a New York Times article that Caroline Hill forwarded to me today, thank you, Caroline, that talks about how the ED visits for mental health, behavioral health conditions have been ramping up very rapidly, even as our total ED volumes are falling. There's also within our work group a lot of numbers that we've shared locally with each other, where the rates of kids who are coming in with more severe suicide attempts, requiring things like transplants and all of the other high-level ICU care has increased. And we are actually putting together a study right now to look at that, to compare it for a certain time frame in 2019 versus 2020, and hopefully we'll have some actual data to share with you. And so what we've done is actually done work to adapt these pathways to a COVID reality, and they're all available through the NIMH website, where you can take a look at how you can modify this to include it in remote work, how you can do this in outpatient settings. The tools, the ASQ itself has been translated in many languages to make sure that we can reach sort of a broad group and a diverse group of patients, because that's another area where there's a disparity, where kids from either SES disadvantaged populations or other disadvantaged populations might not often get picked up, even though they might have more risk factors. So with that, I will stop, and I want to leave plenty of time for discussion and to answer any questions you might have.
Thank you so much for great presentations. There actually are a few questions on the Q&A, and I think one of them actually, Arpa, you answered in typing, but I'm wondering if you can address this for the audience as a whole as well, about the social work demand.
Yeah, and I don't know, Kiari, that you collected any data on that when you were rolling this out, but it's a good point. It did significantly increase work for social work, and I don't know that we have measured that in a robust way. I don't think Rebecca Gates or Dinart Viveros, who led those efforts, are on the Zoom and could chime in, but I think it's a really good piece of feedback, as well as other, when at any time you do sort of quality improvement work, it's really important to think about balancing measures and think about, are you causing some unintended consequences of the improvement in one area? So I appreciate that, and we can take that offline and talk more about it. I know that there's active work happening to increase social work staffing related to increasing the social work resources, related to de-escalation efforts that are starting to happen within the children's hospitals. So there's some overlap there, but we can explore that some more.
If I can add a little bit more, this was always, this was a discussion that we had with our social work leadership, and I really don't want to speak for them, because about, making sure that as we do this, we collect information. And I did not share this because we haven't yet looked at it in a more in-depth way, but we have surveyed our social work colleagues about their experience doing this, both in terms of what is going well, what isn't going well, so that we can make sure that we improve upon the state that we have. And so I think that point is very well taken, and that was our intent and goal from the get-go, to make sure that we keep an eye on that. We have also surveyed all our bedside nurses, not simply on sort of, like, is it feasible, but we are also trying to figure out how much time is this taking, how comfortable people are feeling doing this, do they think it is appropriate, are there other resources they need, are there educational needs? This was a discussion with social work about, do you think there's a role for social work to do this, before we implemented it? And there were a lot of educational, so I think there were 4 educational sort of courses, or 4 separate instances of training before this went live, and a similar number or even more for our nursing colleagues. And so we are asking these questions, and we are actually, the goal is to look at it and improve based on that. So it's always been on our minds, and so I think it's a very well taken point. So thank you for that question.
Okay, can I just ask a clarifying question? So
Yeah.
Because it's a lot of nurses, right, at our children's hospital who are being asked to do this. So that all of them actually complete in-depth training on how to do this and how to respond?
Yeah, so, just so you know, we planned for this for 2 years before it went live. And so it clearly wasn't something that was done in a rush. And the other thing to be aware of is, that we were already doing something, because this was a mandate from the Joint Commission. They were already screening. So it wasn't that none of this was happening and then we like in a vacuum came on and put all of these new things in place. We were asking questions. Our implementation rates were not that great, but we were asking questions about suicide. The difference was those questions were sort of created by committee with our sort of own homegrown team of experts. And it did not have any sort of evidence base behind it. And the big shift was, let's use screening tools that people have put a lot of thought and time and energy, have validated those tools in medical settings. And we know that they will capture the data that we're actually looking for. So it was sort of changing practice rather than implementing something completely new. So the nurses were already asking these questions. They were just asking a different set of questions that are validated and have more evidence that it'll capture what we're trying to capture.
There's a few more questions on the chat here. I'm going to start reading them from in order that they came in. Are there any future thoughts about patients who are receiving active inpatient treatment with a past suicide history who have no current suicidal ideation but test positive due to their history? For example, every 2 to 3 weeks, week admission for up to a year or more for patients receiving chemotherapy treatment. Patients have identified this can be triggering as they are dealing with a life-threatening illness.
Yes, and that's a really good question. And, again, we thought about this a lot as, if you look at the ASQ screen, it's not meant as a repeated measure screen, right? It's a one-time screening tool, but it's a 2-week time frame. So most of the screens can predict out to 2 weeks. And so typically every 2 weeks you could rescreen and that would be okay. But that's sort of as far as the metrics and the theoretical side of this. But in terms of practical implementing, let's say if somebody has had a past suicide attempt, every time they come in, even if they have since gotten mental health care and intervention and are not currently experiencing any suicidality, they will still screen non-acute positive on that screen because of the past attempt. And that will sort of usually trigger a social consult. And that has come up, especially on our hem-onc floors. And we are trying to sort of modify our workflow a little bit to address that, where with the question 4, which says, have you ever tried to kill yourself in the past, if how, when, there's an additional step that we're in the process of adding, which will say, since last hospitalization or since X, Y, and Z, to sort of try and address some of that burnout and fatigue. The other side of this is, that if you look at all the data of suicidality, especially in our hem-onc population, I showed you all the sort of alarming numbers, but when you look at a subset of it, which is our hem-onc patients, they have even higher rates of suicide in that. And there's some literature on like right after diagnosis, those rates are sky high. And so we have to really try and balance that this is a much higher risk population. So we want to screen, but we want to do that in a mindful way so that we are getting the information without burning people out. And this is also like a separate point, like a more global point, is when they validated the screen, the people at NIH, they've also done multiple sort of acceptance studies or acceptability studies for families and for the patients. And consistently the data shows that patients and families are really happy to be screened. They think this is important, they should be screened. Often the biggest feedback is that if they're gonna screen, they should just ask us the questions and be very direct about it and not beat around the bush. And so to me, that's reassuring that globally, most of the time, most of the data shows that it's very acceptable. And then we can take that and look at our hospital settings and make sure we're doing what's in the best interest of our patients.
Thank you. Another question is, I'm curious where the discussion is regarding having clinical psychologist staff our inpatient services.
You're preaching to the choir. I think as soon as we find some funding, I would love it on my team. I think there are, we have some amazing clinical psychology colleagues on a lot of our teams. So IP3 and Christina Benke, a lot of our outpatient clinics and epilepsy. We have, Danielle, who's our psychologist who has very limited time on our team. And I would love nothing more than to have, many more. And there is a discussion that's been ongoing about that. And I think it's multiple things. It's a little bit of it is funding, a little bit of it is, you know, credentialing. And so hopefully it'll move in that direction. But anybody who has, you know, kind of ideas to how to make it happen yesterday, I'm all ears.
One of our colleagues from Oakland is asking whether a similar rubric will be implemented at Oakland, commenting that their child psychiatry inpatient services have been overwhelmed and understaffed for a long time.
And so this is actually, so now there's like a UCSF health-wide initiative to do something around suicide risk screening and standardizing our practices. And one of my colleagues, Weston Fisher, is sort of leading that effort. And I've been working very closely with him and our colleagues in the Oakland side. So that's some of the leadership through the BERT team and their child psychiatry leadership with Regina Graham. And we are, right after this, I actually have a call with them to discuss how we can broaden this and align all our practices to the degree possible. It might not look exactly the same because we have to, you know, kind of make sure that the local realities are taken into account, but it's ongoing.
And then one question asked about resident involvement and says, I heard about the head screen during the resident QC presentations earlier this year. Are the residents still involved in incorporating this screen more consistently in clinic?
I wonder if this was a question directed at me. So unfortunately, I'm a hospitalist, so I don't know a lot about what happens in the outpatient setting. But I welcome any and all resident involvement in our inpatient quality improvement projects. And if anybody would like to partner as far as like bringing some of these tools to the outpatient setting, like the dot phrase, or I know that the tablet healthy check tool is either starting or has already started in the adolescent clinics. So welcome any and all collaboration, but I'm not familiar with what they're doing.
Yeah, I would just add that I think it's so important that we have the head screening both on the inpatient and ambulatory side, right? These two modalities that we've been talking about are complementary. They're not meant to replace each other. So super important.
And it looks like Veronica Mesharikova has been answering that in the adolescent clinic, it's been taking some time, and that's what I had heard, and that's why we hadn't really integrated it into the inpatient setting. I think a lot of this has been, there's been some technical challenges in doing a lot of this work too.
I'm going to give it a moment to see if there's any residual questions or any comments that any of the speaker want to make. And if there's no additional questions, I think it's okay to once in a while end early. Everybody can use 10 minutes between Zoom activities to stretch legs and maybe get a breath of fresh air. So thank you so much for this very informative presentation. I'm handing it over to Dr. Hirsch for the final word.
Thank you, Sandra, and I want to thank all three of you for this really great presentation of a very important topic. And certainly there's a lot that we need to be thinking about in terms of how to really address this important issue in our hospital. So hopefully there'll be more to come. And I think some of the suggestions that have been discussed are definitely very important and timely. Thanks everybody, and enjoy the rest of your week. Bye-bye.